today to talk about measuring outcomes in palliative care. I want you to think about your own life this morning. I want you to think about the things that would be important to you if you found out that life was now limited. Let me ask the question. If you found out today that you would not see the end of the year, who would go to work tomorrow? We've got 3 people who would still go to work tomorrow. Who would not go to work tomorrow? Lots of hands. And really, when we think about what is measurable, we need to project ourselves into the question of what is important, particularly as most of us in this room will have warning of our death. As we improve the health of a community, more and more of us will have warning of our death. And that's a big challenge for us, because it says that we need to think very carefully about what will happen when it's our turn. Self-interest is a really important part of this. So I bring greetings from Australia. This is a koala who took up residence outside our research cottage and stayed there for a whole 10 weeks. So we were very lucky to have him. He is a grumpy old man, and he makes lots of noise at night, but he's very cute. Now, when we think about palliative care, as I go around the world, people tell me, we do good work. And I say, how do you know you do good work? Now, in palliative care, there is a real risk that clinicians, doctors, nurses, allied health will put on lots of weight because we get lots of chocolates and we get lots of cakes from grateful families. And we think that means we must be doing a good job. But when we think about it, letters saying thank you, flowers, chocolates are not from everyone. And the challenge for us is, how do we improve this across the whole of the health system? We also say, well, there are too few resources. We have so little, how can we possibly improve what we do? And so the challenge is that we all believe we are doing a good job. But what we need to do is find ways of measuring the job that we are doing. And so when we look here, the issue is that some services are doing much better than other services. And we're going to talk this morning about a national program, and that national program has been very confronting. It has challenged lots of people who work in this area, because the bottom line is we can always do better. We're at a health accreditation conference which is all about quality of care. And every single part of the health system can do better. Think about the patients that we serve in palliative care. Of all the patients in the health system, they are the most vulnerable. they are the most frail. They are the sickest. And so our patients need us to get it right every time. This is such a frail population that we need to be very, very careful about how we support them. I moved to our national capital, Canberra, 10 years ago to work, and I got a call from a very senior government bureaucrat who had just retired. And I didn't know him. And he said, "We must have coffee." Now, I don't know about you, but when I get one of those anonymous phone calls that says, "We must have coffee," I go, "Okay, let's do it." And so we go for coffee. And I sit down, and his first words to me were, "Do you know what is wrong with palliative care?" I thought, great start to the conversation. Do I know what is wrong with palliative care? And so with that, he said to me, palliative care is currently funded as a social good. It makes the rest of the community feel better about what we are doing, rather than funding palliative care as something that is improving the health of the community. So if you are only awake for 30 seconds this morning, this is the 30 seconds. Palliative care, when it is done well, is about improving the health of the community. Not only the well-being of the person who is facing a life-limiting illness, but also for their caregivers. And in the session at 1 o'clock, we will talk about looking after the patient as well as looking after their caregivers. But we have data that says that this can help improve the health of the community. And that's what we need to be saying to our communities, to our health service planners, to our policymakers, and to our funders, and through them to the communities in which we work. This is not just about being nice to people. This is about improving health. And that's what I want to focus on this morning as we talk. So as we think about that, what are the challenges that we face? This is a study that was done in America, but importantly, there is at least one cross-cultural confirmatory study, which was done in the Chinese-speaking community in Hong Kong. Now, if you go out into a shopping mall today in Bangkok and ask people at that time, what would you like if when you are dying, we get an answer from people who are otherwise well. And that's very difficult. This study specifically targeted people who had been told that their life expectancy was now limited to months. And it was from a range of diagnoses, not just cancer. So as you can see, it also related to end-stage organ failure, in a number of areas, as well as a number of cancers that have a very poor prognosis. And what people said was, we want to tell you what is really important to us. And interestingly, it not only asked patients who had a limited life expectancy, but it also asked their caregivers 6 to 12 months after they had provided care. It asked the doctors who were caring for them, and it also asked nurses and allied health practitioners. At the end of life, what is really important to us? Now, in red, I have highlighted the fact that symptom control, good symptom control, was at the top of everyone's list. The patients, their family and friends, their doctors, their nurses and allied health practitioners. For all of them, good pain and symptom control was at the top of the list. And in palliative care, it is very easy for us to stop there, to believe that symptom control is an end in itself. But in fact, what patients told us is really important. They tell us that symptom control is important so they can do these other things. And these other things include the ability to prepare for the end of life, to have a sense of completion. You know, if you were not going to see the end of this year, only 3 people would still go to work tomorrow from this audience. The rest of you would do something else. And some of those things will be about relationships, friends we want to spend time with, relationships we want to mend, things we want to complete. I remember saying to a patient in clinic one Tuesday afternoon, what is really important to you in the time that you have left to live? And I haven't mentioned dying in that question. What is really important to you in the time that you have left to live? And I was rather surprised by his answer. He said, I want to put in my tax returns for the last 4 years. And I thought, don't you have something better to do with your time between now and dying? But his answer was very beautiful. He said to me, I cannot ask my family to do that. For me to complete that means that they do not have that headache or worry. So for him, this was actually a beautiful gift to his family. He didn't want to do his tax returns. It's the last thing he wanted to do, but his need to complete that so that it was not a burden for his family was really important to him. And so he needed good symptom control, he needed good pain control, but he also needed to be able to think very clearly. He was a businessman with many business interests, and he needed to think clearly right until the end in order to get that work done. I'm sad to see this last one, because it says to me that patients, as they have encountered the health system, may not feel that they have been treated as a whole person. And so the challenge for all of us, particularly as people face the end of life, is how can we ensure that they always feel that they have been treated as a whole person. Now, like all excellent studies, there's a twist. There were a whole lot of things that patients said were important or very important that their doctors, nurses, family and friends did not value. Look at the list. Isn't it interesting? Firstly, maintaining a sense of humour. Who of us, after a really hard week at work, have not enjoyed humour as a coping mechanism? If we have used that all our life, why would we suddenly stop using it because we have a life-limiting illness? 93% of patients, 93% said this was important or very important. Only 50% of doctors said it was important, and only 63% of nurses said it was important or very important. This next one, not being a burden. You know, we talk of dignity therapy for people at the end of life. Can I see the hands of anyone who is looking forward to the day when you or I have to say to someone who is close to us, will you help me bathe? Will you help me go to the bathroom? Will you help dress me? I'm not looking forward to that day. So the issue of being able to function physically for as long as possible is a key goal for patients. And I think we forget too often that that is a goal. We shrug our shoulders and go, of course you're getting weaker. You have advanced cancer, advanced heart failure, AIDS. But a patient-defined goal is to be as independent for as long as possible. And we do not invest enough in physical therapy for people to maintain, not to improve, but to maintain their level of function for as long as possible, to be independent, to get from the bed to the bathroom, to get from the bed to the kitchen. We all value it, and we need to reflect that in what we do for patients. And look at this last one. Patients are not concerned about where they die as long as their family and friends can be with them. Now, we need to replicate studies like this in Thailand. We need to understand in Thailand in 2017 exactly what people want at the end of life. Because if we look at these last 3 slides, we are not delivering that in my country. We are not focusing on independence for as long as possible. And although we focus heavily on symptom control, we generally focus on symptom control as an end in itself. So, when we think about this, what are the patient prioritized issues? 30 years ago, we said, you've got cancer, of course you've got pain. That's no longer acceptable. So can we do that? Of course you're getting weaker and you can do less. We now need to say, how do you and I work together to maintain your physical function for as long as possible. So I want to think about that in terms of the Karnofsky Performance Scale. We don't need to go into detail, but I want to highlight that the level of 70 is absolutely crucial. At 70, you start to need help from other people. So this is an honest scale. 100 is hopefully how you and I feel today. And there is in fact a 0, which is dead. So it's an honest scale. And at 70, we start to need help from other people. Now let me put out a challenge for you. Across the x-axis are the last days of life. And on the y-axis, we have the Karnofsky scale. And we've marked here a line for 70. So remember, below 70, we start to need help from other people. And for many people, this would be a fairly typical functional decline in the last 3 months of life. You may get a small improvement after an acute illness, and then a period which is a plateau, and then a very rapid decline in the last 20 days of life. Now, interestingly, we not only see this in cancer, but in fact, we've got data, prospective data, that says this pattern is very similar in end-stage organ failure. So it becomes interesting. Now, here's the challenge for this morning. What if we could change that trajectory? I want you to notice 2 things. This point has not changed. The patient still dies on the same day. But what has happened instead is that that period is the period of time when the person is independent versus that period of time for which the person is independent. Which trajectory would you like for yourself if you were facing the knowledge that you only had 3 months to live? Who would like scenario 1? Who would like scenario 2? Of course we would. We have not changed when the person dies, but we've doubled the time for which that person is independent. So as we think about measuring the immeasurable, we have randomized, controlled trial data to say that we can change the period of time for which the functional status in people who are better supported with palliative care. So as we think about measuring the unmeasurable, I want us to think about function, because this is something that you and I would value if we faced a life-limiting illness. This is something that you and I would want to maximize if we faced a life-limiting illness. So we need to think about patient-centered measures as we move forward. That's the challenge for us today. What is important to patients? Because if we ask doctors, if we ask nurses, if we ask family and friends, we won't get it right. But if we ask people who are facing a life-limiting illness, we will get really, really important answers. So in the next half hour or so, I would like to look at these 3 issues. Why routinely measure outcomes in palliative care? Secondly, What evidence do we have about current performance directly from patients and caregivers? And I'm just going to illustrate that with a couple of examples. And thirdly, what are initiatives in measuring palliative care and responding to those measurements? It's no good just measuring it. We've got to respond to that measurement. And again, we will look at a very practical example. So why routinely measure palliative care outcomes? The first time I talked about palliative care outcomes that I can recall at a national forum was in 2005. And a lot of people said to me, outcomes? We know everyone dies. What outcome are you going to measure? Now, we have measured lots of process things in palliative care. Time from referral to death, for example, is a process measure. It is not an outcome measure. But we go back to what patients have told us is important. Symptom control. In order to do some other things. So are we making sure that the patient is as well as possible throughout their clinical course in order to allow them those things that will let them complete their life's work, to interact with their family and friends until the end. So what is the value proposition of palliative care? What is it that we say it value adds as we look across the community? There are all sorts of definitions. Lots of those definitions are quite complex. I want to look at a very simple definition. Our work is to optimize the comfort and the function for people as they face a life-limiting illness. And I am not limiting that to physical function or physical comfort. Because when we ask patients what's important, they give us a long list. Physical comfort and physical function. Emotional comfort and emotional function. Spiritual or existential comfort and function. This next one challenges lots of people, but may I illustrate it because this is about personhood, who we are. One of the great joys of my clinical career is that I got to do home visits. Together with having a busy hospital practice and a busy clinic practice, I got to do home visits every Tuesday and every Friday for many years in my clinical practice. And I had seen this particular woman many times in clinic, but she was now no longer well enough to come to clinic. She was only 43. She had two beautiful daughters, and they had just built their home in the mountains. Magnificent. 2-story windows looking out from the family room across the mountains. Very special. And I came in through the hallway, past many rooms, and into this huge family room. For some time, I could not understand, but there was something wrong. In the consultation, I could not work out what was wrong. 25 minutes into the consultation, I suddenly realized This woman had not left that room for 9 days. She had not been to bed. She had not been to another bathroom in the house. There was a small toilet, ensuite, off the family room, and that is all that she had used. And she had not bathed for 9 days. And you think, why would that be? She did not recognize herself in the mirror when she saw herself. She had always come to clinic with her face makeup beautifully done, her clothes immaculate, and she had now lost 1/3 of her weight. She hated her body. She had not been to bed because her husband just wanted to hold her. And whenever anyone touched her, it reminded her that she hated her body. She had not bathed because she would have to soap herself and rinse herself and towel herself dry. And it reminded her how much she hated her body. And if she went to any other bathroom in the house, there were huge mirrors, and she would see herself and be reminded just how much she hated herself. This is about people's sense of self. And her sense of self had changed so much that she didn't know how to cope with it. Socially, how many of our patients die a social death long before they die a physical death? I look after a lot of people with chronic obstructive pulmonary disease, COPD, and a number of them will tell me they died a social death months ago because people stopped coming to visit them and they are no longer well enough to go and visit other people. That even conversations on the telephone become difficult. And so we have that concept of social death long before a physical death. And the financial burden of having a life-limiting illness is huge. We know that. We at least have to ask about it, even if we can't fix it all. But that's the patient. What about the caregiver? We know that caregiving is a health hazard. Caregivers, while in the role and afterwards, have worse health than age-matched people who are not providing care. And this hangover effect, long after they have finished the role, can last for years, not days or weeks, not even months, but years. So if our value proposition is to improve the health of the community, we need to measure not only patient outcomes, but also the well-being of caregivers while in the role and subsequently. So how do we go about finding out what's important to patients? If you've been to communication skills training, you will have been told to ask open questions. How are you today? What's going on? How are things? Good questions. But when we limit ourselves to that, we don't get very much. In fact, in this study, when we asked those open questions, we got a median of just one symptom. When you gave the same patients a checklist with a whole lot of issues that may be important to them, how did that change? It went up to 10, but importantly, it also demonstrated that these were important. Now, when I showed my colleagues these data, they said, 10, that seems a lot. they can't be that bad. They can't either be that intense or that distressing. But in fact, when we look at it, 52% were moderately or severely intense, and 53% of those 10 were considered distressing. So I want to make the case this morning that we must measure what is going on for patients as an outcome measure, not as a process measure. That if we do this systematically, we are going to be very surprised by what we find. Look at the difference here. We ask open questions and we only have one response. We systematically explore symptoms and we get 10 responses, half of which are moderate to severe, half of which are distressing. And when we think about that, they were not only systematically underreported. Of the severe symptoms, 7 out of 10 were simply not reported. So that's a challenge to every clinician who has contact with people at the end of life. It doesn't matter whether you're an oncologist, a cardiologist, a nephrologist, a pulmonologist, or a palliative care physician. These data are a challenge to all of us as clinicians. To look at that graphically, we've got the total number in blue, and in gold we have those that were volunteered. What a contrast. Small gold bar on each of those, big blue bar. We're missing lots as we ask patients about what's going on. So let's look at this in another way. Again, self-report versus systematic questioning. This was a study done by Claire White, very similar to the Homsey study. Admittedly, it was a retrospective study, but what we see is really, really important. The most common self-report symptoms are here for us: pain, bowel disturbance, nausea, mobility, and anorexia. Now, when I look at that list, I think that we have very well-trained patients. And by that I mean, when we hear that someone has a life-limiting illness, we go, "Do you have any pain?" And so they tell us about the pain. Why do we ask about pain? Because generally we can do something about it. Now, when we actually ask people, what is the number one symptom that people have with a life-limiting illness? What's the number one symptom? Is it pain? What is it? Fatigue. Overwhelming fatigue. Fatigue that is not fixed by a good night's sleep. And yet, where does it appear on this list? It doesn't, because our patients have been well trained by you and by me. We say, "Do you have pain?" So they think, I've got to tell the doctor or the nurse about pain. Do you have nausea? Why? We can do something about it. So I've got to tell my doctor or nurse about nausea. We train our patients in their history. And yet when we move from that, my goodness, systematic questioning, the list looks quite different. Weight loss is a major concern to people. And you know, we now have potentially in the wings the first treatment for cachexia that will be registered internationally. Fatigue is next on the list. And when people say, "I've got fatigue," what do you and I do? Well, you've got advanced cancer. Of course you're tired. Anorexia comes in third here, not fifth. And we get to things like low mood. We get to things like mobility problems, confusion and memory loss. Our patients are very well trained. So when we think about measurement, it can't be you and I asking the questions. We've got to think about how we're going to get information from patients that is sufficiently objective. So what evidence do we have about current performance directly from patients and caregivers? Well, let's think about that. Firstly, we decided in a national program to ask caregivers and patients away from the bedside, as a palliative care service, how are we doing? So it was not the doctor saying, how is your symptom control? Or how is my performance as your doctor? It was actually giving people a questionnaire, telling them to take it home, send it back anonymously to be evaluated nationally. Okay? Very different to you and I asking at the bedside. How did we do? Who thought we did really, really well? Anyone think we do really, really well with this? Not seeing any hands. We did pretty well. Any hands for that? I got a couple of hands for it. Thank you very much, and thank you, sir, against the gentleman in the grey jacket. Who thinks we did fairly badly? Who thinks we did really badly? It's interesting. So when we think about measurement, we need to be clear that you and I asking the patient at the bedside may not be a terribly good way of finding out how we did. So let's look at the results. We used the Palliative Outcomes Scale, the scale from Professor Irene Higginson in King's College London. It looks at symptoms, psychosocial support and information, and a couple of items on the practical support offered to that patient or their family. So let's look at pain. When we asked about pain, we actually got a fairly bad report card. We tell the community, we tell our colleagues where really we are really good at symptom control. 25% of respondents, and these are people seeing a palliative care service, said they had pain that was severe or overwhelming. Now, when I first showed this to a couple of colleagues, one of them said, and I quote, "I do not believe those findings. I see these patients on the ward and no one is complaining." Firstly, pain is a subjective experience. The patient says, "I have pain," they have pain. Simple. Secondly, I think patients give up telling us. First consultation, you've got some pain. I can do something for you. I can do something about that. Second consultation, is it better? Perhaps a little bit better. Well, I can make another change to your medication. I will get it better. Third consultation, is it better? I'm not sure. Perhaps a little bit better. Remember, patients want to please us. They want to please their doctors, their nurses, their pharmacists, their physiotherapists. Fourth consultation, perhaps a little bit better. Fifth consultation, how's your pain? Fine. When you hear a patient tell you their symptoms are fine, be really, really worried. What about the other symptoms? 1 in 6 people had severe or overwhelming symptoms. These are people seeing a palliative care service. These are the lucky ones that have found their way through the health system to actually see a palliative care service. This is not an unselected population from across the community. And when we asked the caregivers in exactly the same survey, 78% of caregivers said they were anxious. 9 out of 10 families said they were anxious. And 1 in 5 said that they had severe or overwhelming anxiety as a caregiver. I want you just to stop and think for 10 seconds this morning what we ask of caregivers. Nurse, chauffeur, pharmacist, bottle wash, laundry person, friend, confidant, lover, doctor sometimes. We ask caregivers to make decisions about as-needed medications. Is the person in enough pain for me to give some more medication? Is the person's nausea severe enough, or they just vomited? What should I do with the medication I gave 10 minutes ago? We ask a lot of caregivers. And what about family anxiety? Almost 1 in 2 families are saying they are anxious or are overwhelmingly anxious. That's a lot of people. That's a lot of people. So we have a real challenge as we start to measure, and we don't necessarily need to measure everything for every patient to get these sort of patterns. This is a good study. 1,800 surveys were sent out. We don't have to measure every single patient to get a very good picture of what is happening. Now, these data are not limited to Australia. This is a study from England which followed back from death certificates to find out what had happened to care in the last year of life for that person. And when we look at it, 88% of people reported that they were in pain that was relatively poorly controlled at some stage in that year. Who wants to have relatively poorly controlled pain at the end of life? So why can't we deliver this systematically across our communities? This is a study from Canada where they've got point of care data collection for more than 60% of their oncology services across Ontario. Ontario is the size of France. It is huge, and yet they've managed to get point of care data collection. More than half of the patients reported pain or shortness of breath, about half of whom reported moderate to severe scores, almost identical to the Australian data of 22 and 17%, almost identical. So as we measure the immeasurable, let's start with the patient. Let's actually ask them away from the bedside, away from the clinic consultation, how are we doing? Because when we ask them, the news is not as good as we would like it to be. And again, if we look at that same study, lung cancer patients had the worst burden of symptoms. What is the adult smoking rate in Thailand today? I don't know the figure, but I know it's substantial, and I know the burden of lung cancer that is going to hit Thailand in the next 30 years is substantial. This is a group of people systematically who have a massive burden of symptoms. So let's look at the initiatives beyond that paper by Tanya Pigeon and understand what we may be able to do. Some of you may be aware of the Choosing Wisely campaign from the Institute of Medicine Foundation in the United States. They asked many specialties and subspecialties to identify 5 low-value things that could be stopped that would either not affect health or may even improve it. They were specifically asked to focus on their own specialty or subspecialty. In palliative care, we ignored that direction. And so instead of looking at our own performance, we looked at the performance of cardiology, radiation oncology, and geriatrics. And we looked at other people's low-value healthcare proposals and practices and said, don't do those things. Now that's kind of sad, really, because there are things that we need to do better and low-value things that we can drop off what we do. But a challenge for palliative care right around the world is that we have no gold standard for referral. So when we say to family physicians, you referred too late, they correctly say, when should we refer? Where is the document that helps me as a family physician refer in a more timely way to your service? When we say to the oncologist, but you left it too late, the oncologist says to us, but where is the document that helps me decide when I should initiate referral to palliative care? And we have the challenge that there are multiple entry points and care is provided by a large number of health professionals in a large number of clinical settings. That is the nature of palliative care. It is the nature of life-limiting illnesses. So the real question is, how does that fit into us thinking about measurement? We have a number of processes from around the world. This is from Sidney Dye at Johns Hopkins in Baltimore. Together with the American Academy of Hospice and Palliative Medicine and Hospice and Palliative Nurses Association, we have a number of key areas that are thought to reflect quality in palliative care. And if we look at the list, firstly, we need a comprehensive assessment taken directly from the World Health Organization definition. We need to look at things physically, and I'm delighted that both pain and breathlessness are actually singled out for their particular impact on people as we face a life-limiting illness. The psychological and psychiatric needs. It's easy for us at times to focus on the psychological at a cost that we may not have recognized the psychiatric. Again, the spiritual, existential, or religious concerns. Ensuring that we give people permission to raise those issues is a key part of a good assessment for the end of life. And then a whole lot of ethical and legal aspects. It's a good model. It's one of many, but it's a good model. We've got those organisations that are now starting to measure outcomes, and this is the group of David Casseret from Philadelphia and his team, where they've used services that have the same electronic medical record, and with that they have been able to start to bring together performance data across the United States. Arif Kamal and a group from the Carolinas, North Carolina and South Carolina in the United States have brought together a number of questions within 5 domains to see how we can improve, understand the care we offer and improve it. Basic demographics, symptom management, advanced care planning, understanding prognosis, and how patients make transitions across the health system. And when we look at that, we can see that you can build very quickly a picture of what is happening around the responding teams as we move forward. These are early data from the team way back in 2011, and they have continued to grow since then. They just haven't necessarily updated all of the data. In Australia, we have, since 2005, been building a national collaborative to look at outcomes in palliative care. And this is derived from point of care data. It is prospective, and it is specifically asking us to collect key data to ensure that we understand what is happening for patients and their families. It's had several benefits that we didn't necessarily expect. Firstly, it has created a common language for clinicians, and that is really important. For family physicians talking to palliative care services, for palliative care services talking to family physicians, for palliative care services talking to other members of their own team. All of them have created a common language through this. It supports outcomes improvement. I cannot stress strongly enough how important that is. As we brought services together, every service told us what an excellent job they were doing. And in fact, some of our biggest and most well-resourced services told us they didn't even need to do this because they knew they were excellent. Be very careful, dear colleagues, when a service tells you that they know they are excellent and so don't need to participate. Because some of those services came in and they were not at the top. In fact, they were well down the performance list and have had to work really hard to catch up with many smaller services, many of which have not been as well resourced. So this has been very challenging for some of the services who've participated. The aims of this were simple: to collect data, not as an end, but to analyse those data, to benchmark, and to systematically improve outcomes. So for that you have to collect data, but you have to analyse it, feed it back, benchmark it, and then take it through to systems improvement. Have we managed to do that? So how do we compare with other similar services? In many areas of health, we do this very poorly. We do not actually understand what the cardiology service 2 hospitals away does that might be different or similar, and how that translates into outcomes. It also asks us to think about best practice. not only good practice, but what is the best practice in this particular area in terms of assessment, in terms of treatment, in terms of thinking about outcomes. And so this incorporates, as we noted earlier, palliative care is across a range of settings. And so this incorporates community care, home care, inpatient services that provide consultations, and inpatient services that provide direct care. All three of them are part of the program. And there is this virtuous cycle, a cycle that says point of care data collection, routine reporting, benchmarking, structured feedback, and hopefully in here, the magic happens. That in here, we have services go away and think, what can we do better? How can we improve outcomes for patients or caregivers? The architecture is quite simple. Collect the demographic data just once. Collect some key indicators every time the person changes where they are. So as they move from home to hospital, you would collect some specific data at that time. As they move from hospital to a skilled nursing facility, you would collect specific data at that time. And then some data around every phase. And there are essentially 4 clinical phases: stable, unstable, deteriorating, and terminal. And when we think about that, there are many people where the stable is not just about symptoms, it's about the whole care for that person. The unstable is where you have to urgently change your care plan in order to respond to unexpected needs. Deteriorating is what we expect as patients get sicker. And terminal are the last days or hours of life where the person is actively dying. And in fact, in terms of the resources that you and I need to use, unstable and terminal are very similar. Stable and deteriorating are very similar. So we've got 2 pairs within that help us to understand the resources that are required, the intensity of those resources. So again, point of care data collection, and really just 5 assessment tools. And I want to focus on what they are. Phase, which we just discussed, a more detailed use of resources, particularly around eating, self-care as the focus there. Something to measure function. Patients value function in order not to be a burden. So we've got to measure it, and we've got to understand how that looks. Problem severity score and symptom assessment score. So symptoms, function, and phase. 3 domains. And at the moment, there are a group of people working from Europe, North America, Australasia, and Asia in order to understand the domains. But I think the domains will have function and symptoms as their core. Symptom assessment scale is patient-reported. Palliative care problem severity is clinician-reported. And I think we need to be really careful about clinician-reported symptoms. We're not nearly as good as we think. And this is routine, it's voluntary. As we saw earlier, there are periodic snapshots. That was that survey of 1,800 patients and 1,800 caregivers, and some experimental ones. What does that look like overall? We've been collecting data now since 2006. And what we need to understand is the variation due to the mix of patients, variation due to the mix of practice, and variations in patient-centered outcomes as a result. So if we look at the data, what I want to say is that we have a huge data set, and importantly, we have been able to look at this, to anchor the data, and to provide timely feedback. What I most want to say today is that we have demonstrated for the first time at a national level that palliative care services can improve their performance. So when we talk about measuring the unmeasurable, we can measure. We can not only measure, we can improve. So let's look at that. This was pain over a 3-year period. Pain nationally improved. Look at the improvement in other symptoms, really quite marked. When we look at the family caregiver scores, they improved because people started to get feedback, started to benchmark, and started to look at their practice. When we look at psychological and spiritual functioning, we see some real improvements. Another pain score, nausea, improving dramatically up here in the light blue. And finally, breathlessness. Look at that. In breathlessness, we've gone from the mid-60s to the mid-70s in that 3-year period nationally. Not only can we measure, we can improve. And I want to see those numbers much better again as we move forward. In fact, I'm delighted to say I've seen the most recent data for pain, and we have really lifted our performance there in the subsequent 3 years. We can measure, we can analyze, we can benchmark, and most importantly, we can improve patient symptom control. If we take bowel problems, even they've improved a bit. Just to look at breathing, what does that look like? I suppose the important factor is over the same time period, we've gone from about there to about there. We can improve what we do, and through that, we can make a real difference. So if we look at this as we move forward, we have had statistically significant improvements in all domains, and most importantly, we have had clinically significant improvement in all of those domains. Whether we look at pain, whether we look at nausea, breathing, bowels, pain, family caregivers, psychological and spiritual or other symptoms, statistically significant improvement and much less variation between services. That is another way of saying we are getting better, seriously getting better. So in summary, we've got a series of outcome measures for a broad range of aspects of quality improvement that is building a culture of improvement. Palliative care is no different to any other area of clinical care. We have to improve and show the community, show our colleagues that we are indeed improving. Variations that were seen were not simply because of resources. In fact, some of our least well-resourced services deliver some great outcomes. And so we need to be aware of that as we move forward. We need to learn from each other and continue to drive better outcomes. Ladies and gentlemen, this morning I want to convey to you that with the systematic collection of key patient-centered data, with a feedback loop and benchmarking, we can do a much better job at patient-centered outcomes for people as they face a life-limiting illness. It is a challenge right across the world, and I'm delighted that Thailand is taking the time and effort to think now about how to measure these crucially important outcomes. Have a wonderful day.